All right. Thank you for joining me, Dr. Klein. So tell me about yourself. I have known you for over 20 years, and you have
Right.
helped our patients and myself so many times. And I love your work. You have anointed hands. I just
Thank
want
you.
to know, how do you get into this? How do you start it? And tell me your story.
Well, I mean, I actually was a patient before I became a therapist. I was involved in a car accident when I was 19 years old, and I had multiple fractures, including my mandible. Um, and that's how I actually got started in the field, uh, and decided, having gone through physical therapy, that might be a good fit for me. And it turned out to be a really good fit. And I graduated physical therapy school in 1983.
Wow, that was
And
amazing.
yeah, and I started working at that time in hospitals, which is a great place for new grads. I always recommend new grads because you get exposed to everything. You'll see everything from orthopedics, neurology, and even wound care. Um, and at that time, I kind of was interested in everything, but really hadn't found my particular niche yet. And then I moved to Florida in '84
Mhm.
and started working at Holy Cross. And actually found out I really didn't like it too much. It was at that time they had me just doing neuro. So I left there and started doing per diem work and found I really liked orthopedics. And probably in 1986, I went to a course that was given by this doctor named Mariana Roccabato from Santiago, Chile.
Mhm.
He was here lecturing. And when I got to the course, there was half dentists and half physical therapists in the class. And I was blown away by that. I had never been to a course. I said, now, what does this physical therapist have to say that all these dentists are interested in? And the course was called Introduction to Head and Neck. And that's where it really started, as far as looking at temporomandibular joint disorders as a niche practice for myself. And it was such a really unknown area for physical therapists at the time, even for dentists, I believe.
Mhm.
But at the end of the course was really cool. They actually kind of walked you through the process of marketing yourself. And I started renting space and subletting space in a doctor's office, a podiatrist. Turned out to be out in Davie, which I had never been that far out. But and that's how I started. I started getting dental referrals back in 1986, and
Wow.
at this point, I've seen well over 1,000 cases and nearly 35 years of practice.
Amazing.
Yeah,
Mhm.
yeah,
So, we are so grateful because nowadays, I don't know what your experience has been with this COVID, and the increase of anxiety is out of control. I've
yes,
seen so many patients coming with migraines, TMJ problem, the jaw
right,
disease, cracked teeth,
right,
down teeth,
right.
sensitivity. So what have you seen with the COVID?
Yes, sort of reminiscent of the influx of patients with head and neck we saw after Hurricane Andrew back in '92
Um,
with these stress disorders. So really, I think it all really is a manifestation of the sympathetic nervous system, which we're all familiar with, and its effect on the body, which is designed to tighten up the head and neck muscles in response to danger, stress, anger, fear, pain. The problem, of course, is that we're being exposed to that level of stress on a continual basis for long periods of time. And so we're seeing the effects of that system on overload for just too long a period of time in our patients. So
Right,
something that was designed to help protect us
right,
is sort of now working against us.
right. So, you're a lifesaver. I do a lot of reconstructive, full mouth reconstruction work, and I tell my patients, before I start, I need for you to see Dr. Klein. And they don't comprehend why
Right.
is it that I'm telling them to see you.
Yeah.
So how will you speak to a patient? Maybe I'm too technical. How do you speak to the patient so they comprehend the importance of the treatment before dental work?
Going back to the first course I took, Rakabato did a demo where he asked everyone in the class to stand up. And we all stood up and he said, okay, now lightly tilt your head back into extension and lightly bite down. And you notice that your occlusion has shifted. As your bite is such that your mandible is now slid posterior to your maxillary teeth. And then if you bend your head forward all the way, you notice that your mandible has sort of slid forward when you bite down.
Right.
So this, light bulb went on that the cervical spine posture can affect the occlusion. And at that time, we looked at a correlation between a forward head posture and which the dentist refer to as a class 2 occlusion. That is a mandible being sort of slid posterior due to the influence of the soft tissue, that is the muscles attaching to the mandible from the neck, exerting a force on the mandible as a result of a faulty posture.
Mm-hmm.
So one of the things that we do in the evaluation of the patient is to look at them from a postural perspective and look at what are the forces on that joint. Mm-hmm. We talked earlier about the stress and how the stress may affect and result in increased tension on the cheek and jaw muscles. We're now talking about mechanical effect. That is, what is the mechanical effect of the soft tissue, the muscles in this case, exerting a force on the mandible? So that is a result of specifically the cervical spine posture. So that's one thing we look at. So as a physical therapist, I'm looking at the whole person, and specifically when a patient comes from me referred to your office, I'm looking at what are the effects on the temporomandibular joint and the occlusion. Mm-hmm. And we want to complement what you're doing and make sure that what you're doing is going to be done in a way that I'm going to do what I can to help ensure the success of your approach.
Yeah. So we have a lot of patients that have destroyed the crown, right. The vertical dimension, which is the distance, between the maxilla and the mandible.
Right.
We're trying to restore that.
Right.
Maybe from 18, they're at 15, and then they have destroyed all the incisal edges, and the back teeth are flat, and they're hitting prematurely on the condyle. So the patients, what I tell them is, you must see Dr. Klein,
right?
Because you wore out the teeth that God gave you,
right?
You wore out the teeth that the last dentist gave you. So I want to ensure success on the teeth that we are giving you now, and I need cooperation, to be a team mentality, because a lot of patients don't comprehend that is the wear and tear in the bruxism. What are the things that you recommend for a patient after they see you to maintain the new posture or what you're doing?
Right. Well, the first thing is going back to the bruxism and really understanding a lot of times the patient is totally unaware of that.
Right.
And so one of the things that we will do is identify whether they have signs and symptoms of bruxism, and then look at the health of the joints. A lot of patients are even unaware that there's popping, clicking in their joints, the temporomandibular joints I'm referring to. Mm-hmm. So that's one thing we're going to look at that and put them aware and explain to them what we're seeing, and put them on notice that, this is what's going on, and this is what we want to see you succeed. We don't want to see you destroy these beautiful new teeth that Dr. Cintron is going to give you. Mm-hmm. And so let's work on that. So there's a variety of different methods that we're going to use to address that. Typically, where I'll start was just really, again, making the patient aware of that and really talk about not just the posture of the head and neck, but the posture of the mouth, really call the physiology of the mouth and what is the rest position of the mouth. And it's amazing, agree with me, you'll find patients who are literally clenched all day long and think that it's normal.
Right.
And so we try to teach them about that freeway space we should have between our teeth, that position of rest of the mouth. And it's a concept that is taught many different ways. And I found, I'm not sure about what you do, but I have found the easiest way to explain it is to really look at the position of your mouth, the posture of your mouth after the swallowing sequence. You notice that after you swallow, your teeth drop apart, your tongue's on the roof of your mouth. That's the rest position of the mouth. That's where we want you to be, not clenched. And it's surprising, but a lot of patients are not even aware that they're clenched all day long. They think that's normal posture. So it's just an awareness is the first step. There are techniques that we additionally will teach them to help overcome that, including relaxation techniques and certain exercises if they require some, we call lingual re-education. Some patients have actually an adult tongue thrust. They may have residual tongue thrust and require some lingual re-education to relearn their swallowing patterns and so forth. So it's an individual situation that we look at the patient, try to see what's going on, try to see what's led to all this bruxism, and see if we can intervene. And that's one of the ways I start approaching the case. But again, looking at the whole patient and from at least from a physiological point of view, what's going on with this patient. Sometimes as physical therapists, we're not going to be privy to get so much involved in their psychological life and see what the stresses are on their psychological stresses on them, just to sort of make them aware that, hey, it's manifesting itself in excessive grinding and clenching of your teeth, and you really have ruined your teeth or caused damage to the joints. And we want to try to address that before we proceed with these beautiful new teeth that Dr. Cintron is going to give you. So I think that's sort of a nutshell why it's important to proceed on pre-procedures for them.
Huge. If I had a choice, I would have the patient see you, then a psychologist,
right,
to address the stresses and how are they managing life, because
right.
They are most probably right now connected to fight or flight. They are thinking that being on that state of emergency, emotional state is normal, and the adrenals are fatigued producing cortisol. So women find themselves going into menopause prematurely because we only have a bag of flour, and that flour is going to make all the hormones, right?
Right.
So you have the cortisol, and then it's like, why are you producing cortisol all day long? You're not supposed to.
Right.
So, want them.
So briefly, just to expand upon what you're talking about, that fight or flight system, I mentioned a couple of symptoms such as clenching and tensing of the neck muscles. There's a whole cascade of symptoms that occur, including heart rate increase, a dilation of pupils. A lot of our patients are coming to us with sensitivity to light because their pupils are dilated from excessive sympathetic overload. The digestion is slow. They're coming with digestive issues. So there's a whole cascade of symptoms that occur along with the sympathetic overload or the fight or flight response. So,
Exactly.
Fortunately, but that's the reality of today's life. We are constantly exposed to a certain level of stress in our life. And that system, I think, developed to respond to brief periods of danger. But now we're just seeing that system on overload continuously.
Yeah, 24/7. So, I'm very daring when I speak to my patients. I go into what is it that makes you a person and a human. So we go into your mind. What is your connection with God? What is your connection with your thoughts? What are your thoughts? Are they positive? Are they empowering you? What are your habits? Are you working out? So I gave them a whole sheet about
Right.
journaling, about praying, about walking, about exercising twice a day. Because if you're
Right.
breaking your teeth and you're breaking your joint, it's like you got to do something
Right.
different to get a different result.
Right.
So,
And it's very individual. I find that, everybody seems to have hopefully some method of coping. It could be exercise. It could be music. It could be meditation. It could be religion. It could be a number of different coping mechanisms.
mhm.
And I remember one particular patient told me that she had to sit there with a coffee and pet her cat for like 2 hours in the morning. And that was her stress management
That's
for
wonderful.
the day. And that's what worked for her. So it can be very individual. And I think we need, as clinicians, we just need to suggest the patient, identify the issue for them, help identify the issue, crystallize the issue for them, and present multiple coping mechanisms for them. And again, if it's beyond our area of expertise, I would also agree with you, recommend the patient see a psychologist or psychiatrist.
Yeah. We do a lot of times because if you cannot control your anxiety and it's causing all this damage, you know that if they don't do something different, then they're going to get the same result that they came with. They're going to grind the teeth again. They're going to pop the crowns out, and they're going
Right.
to be unhappy, thinking that the quality of the work was not appropriate or adequate. When it's that if you're breaking with a hammer your furniture, you're going to break it.
Exactly.
Tell me a little bit about the symptoms that people get when they are grinding. Like I have patients that have tinnitus, and they don't relate it to the clenching. What other things do you see, besides those migraines, tinnitus, locking of the jaws? So,
Okay, so you mentioned three things before. If we have time to go through them quickly, we will.
yes.
Okay, so let's briefly. You mentioned headaches, and typically we address two, and there are multiple types of headaches. The migraine headache, or what's like about a classic migraine head, it's typically in a vascular event. It's unilateral pain over one eye, lasts 12 to 36 hours. It's associated with nausea, vomiting, visual disturbances. That's a classic migraine or vascular event. We also have the classic tension headache, which is more a result of a muscular event. And we typically, as physical therapists, I typically address more of the muscular tension headaches. And that would be headaches caused by pain referred not just from the neck muscles, but also the muscles of mastication. As you know, for example, the main chewing muscle, the masseter, can refer pain over the eye, as well as into the ear and teeth. So it's sort of a map, a road map. When a patient comes in and says it hurts here, we have to sort of trace it back and do our evaluation and see where they're coming from. And the reality is it could be a mixed event as well. It could be a muscular event along with a vascular event. So the patient's coming to us with a variety of different symptoms, disorders, and it's up to us to sort of address and kind of listen to the history, listen to the symptoms, and then evaluate the patient and see what the source of it is. We may need to involve a neurologist at times if it's a purely vascular event. But in general, what we're typically seeing is patients with referred pain headaches that are referred from the muscles of mastication, the jaw muscles, and or the neck muscles. That's what typically is producing the headache patterns.
And
And these patients can have sensitivity to light as well, sensitivity to sound. It's not just a pure vascular event that can produce those symptoms. Patients often mistake severe headaches as just being purely a vascular or migraine headache. They can certainly be a headache of muscular origin. The next thing you mentioned was tinnitus. And tinnitus is a ringing of the ear. It can be a throbbing sound, a pulsatile tinnitus. It can be a roaring sound. It's described in many different ways. Estimates 15 to 20% of the population have some form of tinnitus. typically occurs in more often in men and typically over 60 in age-related situations. What we're typically involved with primarily, and it's a huge subject, and there's tons of things that are being done for it. We're typically, that is, as a physical therapist, what I'm typically involved with is the deep masseter. The masseter muscle, the main crushing, chewing muscle of the mouth, can produce tinnitus. And that's really a great finding when if you can relieve that for a patient. And it may have been there for years. It can last a lifetime. But that's a home run. If we can find that particular muscle causing the problem, we can treat that patient's pain pattern and the tinnitus, and everything can resolve for them. And so that's tinnitus. The last thing I think you mentioned was locking of the jaw.
Yes.
Okay, so now we have a big subject. I'm not sure how our time is, but I'll just kind of briefly, let me go through the less frequently seen things first before we get into the meat and potatoes of the. So the locking, as you put it, of the jaw. So one of the things that we have been seeing for years, and I'm talking about the less common things we see first.
Yeah.
All right. Let's get that out of the way first, because it is a real problem. And you may have seen it from other dentists, that is trismus that occurs post-dental procedures. These patients are typically men. They typically have a history of having quote unquote difficulty getting numb. They may have had, and they require multiple injections. And they come in with very limited range of motion, maybe just a couple of millimeters of anything. And this is thought to be caused by a hematoma that can form, or just some bleeding that can occur post-injection. This is, again, a little bit more rare and typically occurring just in men. I haven't really seen any women come in with this. And it typically resolves in about 6 to 12 weeks. Again, it was interesting because I had been seeing it for years, but turns out I had two physicians come in. One was a cardiologist, I believe, and the other was I think he was a neurologist. And I tried to reassure them that they'd be fine in 6 weeks, and this was something we typically see, but they insisted upon MRIs. And so we got the MRI, came back that there was some bleeding into the temporalis. So this is something you may want to comment on, the difficulty of injecting a man versus a woman as far as the size of the musculature and getting that needle really where you need to be. So I think in these cases, what we ultimately conclude is that sometimes that the injection has led to some bleeding into the muscles of mastication, causes the lockdown. It does resolve typically in about 6 to 12 weeks, along with that blood or hematoma resolving.
Wow. Yeah. Well, when I inject the mandible, being a woman or a man, because some women have huge mandibles too.
Right.
And I go to Nigeria. I work in a dental clinic in Nigeria, and the jaws are humongous. So, when you go to dental school, one of the basic things that you learn is the injection techniques. So to me, that's one of the most important things that any dentist can learn in their career, because I found throughout the years that I was hiring associates that they did not know how to inject the patient. So, measuring the landmarks before you even touch a patient, you have to see the width of the mandible or the location of the inferior alveolus coming. And then also when you are measuring and dissecting that mandible, when you're injecting, you have to hit the bone and retrieve and make sure you're not in a vessel. So
right.
In 32 years, I have never had an issue with that, but I have seen how it can happen because of my experience with certain dentists trained in different facilities,
Right.
Everybody that goes to that school, they don't know how to do inferior alveolar.
Right.
No coincidence, but
right.
That is when
it's a testament to your expertise that you haven't had this issue.
I hire an associate and make sure that I say, let's review your injection technique.
Well, I've never seen one from your office, but they do occur. And
Yes.
they occur quite frequently. I only see, of course, some of them. So
Yes.
I don't really know how many are out there. The other one I want to briefly touch on is oral cancers and post-radiation scarring. I do see, unfortunately, again, typically men coming in with very limited range of motion. They've been diagnosed with oral cancer sometimes. They've gone through frequently radical neck dissections, and they have to have radiation. And the radiation produces scarring. And they may come in with very, very limited range of motion as well.
Mm-hmm.
And to complicate things further, the radiation may have damaged their teeth.
Yes.
So you don't really have anything really solid to work against when you're doing your manual manipulation. I do find actually the old tongue depressors to be very effective in these particular cases.
Mm-hmm.
And that's one of the main things that I utilize in these really difficult post-radiation scar, limited range of motion.
Yeah.
So the big subject of internal derangement or temporomandibular joint disorders.
Yes.
So, and I think the easiest way to talk about it is we know the temporomandibular joint is that joint formed between the mandible and the skull. And it's sort of analogous to the knee in that there's a meniscus between the bones, that is between the socket and the jawbone. There's a piece of cartilage we refer to as a meniscus. That meniscus is firmly held in place on top of the jawbone by several ligaments. And through a process of microtrauma, such as bruxing for long periods of time, or significant trauma, such as an accident or assault, we see that meniscus has become the ligaments that hold the meniscus in place on top of the jawbone becomes damaged, and the meniscus can begin to slide or move, and typically it moves sort of in a specific pattern they call anteriorly, and so that can produce a clicking sound in the joint as the patient opens. And the click is actually a recapturing of the meniscus as the patient opens their mouth.
Mm-hmm.
The issue with that is the ligaments are damaged, and so typically when they close their mouth, it'll just fall off the disc. So every single time the patient opens their mouth, there'll be a click. Now, this is what we call the early stage of the issue. When the meniscus can become so displaced, it can actually mechanically block the mandible or the jawbone from moving forward. And that's what we refer to as an acute closed lock situation, or an anterior displaced disc without reduction. This is more often a female problem. And it's typically, it does occur in men, rarely, but they typically have histories of extreme bruxism and or trauma. So typically we do see mostly women with this issue. And that is sort of a quick explanation of temporomandibular joint disorders. So the treatment, briefly, if the patient is clicking, popping, the issue is going to be more symptomatic in teaching them how to sometimes limit the motion. A lot of times these patients are coming to us with hypermobility. Again, this is a female issue. One of the thoughts as to why this is more of a female problem is that the joint is held together by ligaments. And we look at women as typically more flexible than men, that their ligaments are softer, more mobile. And so we think this is a risk factor for the development of internal derangement per se. So in this clicking phase, we're looking to sort of put the system at rest, sometimes limit the motion, their opening, and then treat the symptoms that are going on, whether it's inflammation in the joint, pain in the muscles, and so forth. If the patient is in that later stage of locking, the disc is so displaced, they may have a very limited range of motion. In those particular cases, we can typically get the patient to at least 35 millimeters, which is a functional range of motion, regardless of where the disc is. It's also important to point out that internal derangement does not necessarily have to be painful. That these patients can have popping, clicking, even locking, and have no pain associated with it. Some estimates are about 40% of people will pop and click, and only about 1 or 2% of these patients have pain associated with it. Mm-hmm. So it's a more rare situation. The patient presents to us with a clicking and locking with pain. But that's why part of the reason it's very important to point out to the patient, did you know you were clicking? Did you know you were locked? A lot of patients are unaware. They're coming to us already with displaced discs. And we have to very carefully point out to the patient they have internal derangement. They'll throw their hands up and say, I have no pain, and that's fine. Just letting you know that, explaining that. I mean, this is what's going on. Nothing to worry about right now. It's something we want to keep an eye on.
Right. And what about the hormones? You know, do you find that
Exactly.
that are getting close to changes in hormones have an incidence that is higher than women that are younger?
Right. And this is, the typical case that I see of popping, clicking, locking. This is generally a young female issue, the popping, clicking phase. We do see our older patients come in with more arthritic temporomandibular joints much later phase in life typically. But very typically, teenagers will come in popping, clicking, and sometimes locking. And again, you look at the flexibility of a younger person, and if we can look at their flexibility and assume that the ligaments holding the disc in place are also as flexible, you can see with the forces put on their mandible that they are at high risk for internal derangement.
Yes. So what would you recommend on that?
Well, the first thing is always we look at the patient and we try to figure out what are the forces on the joint. Are there excessive forces? Does the patient have oral habits such as biting on pens, pencils, fingernails? Are they bruxing, clenching? So that's the first thing, to identify any excessive mechanical forces that are on the joint and try to put the system at rest. It's always my first approach with a patient is to try to put the system at rest. You can do a number of different things. You can give them brand new teeth, but they continue to abuse their teeth and the muscles and joints around it with abnormal oral habits such as excessive clenching, bruxing, biting on pens, pencils, fingernails. They're going to break down whatever we do for them. So it's really important to start from going back to what we talked about initially. Try to put the system at rest. Try to restore the physiology or the posture of the mouth, if you will. And that's an educational process. And again, these are habits that require a lot of training. Typically, it can take at least a month to change a habit of bruxism or clenching. And, especially with young girls coming into me, I'll say to the mom, listen, go get them if they're biting your fingernails, go get them a manicure. Give them a reason not to bite those fingernails, So some of these habits are difficult to break, but they need to be identified and addressed if we want to succeed. If I want to succeed as a therapist, and I want you to succeed in what you're doing for their occlusion and their teeth. So
you mentioned, cancer patients. We see a lot of cancer patients, but when you said that, I thought about what about patients that have hurt it so bad that they might need surgery? What do you think of that? Is surgery helpful at all? Have you seen any good things?
Well, I think there are indications for surgery in some cases. But again, I would say that if you look at the statistics, that most patients are going to get better first of all, most patients are going to get better on their own without our intervention. The body has tremendous healing abilities. If we look at a fracture heal, we look at a wound heal, we know the body has tremendous healing abilities. The patients who are sort of stuck in a cycle where they're not getting better, I would say the vast majority, 80 to 90% of those patients will get better with conservative care. Yeah. That is some type of physical therapy and an approach from you, whether it be an appliance or whether it be a restoration of their occlusion. That can be enough in, I would say, the vast majority of the cases. In advanced cases, and some cases where there's rheumatoid arthritis or there's other significant trauma to the case, they may need some surgical intervention to assist in the recovery. And that is a whole huge subject, anywhere from what's called an arthrocentesis, where they're just sort of flushing the joint with fluid, to an arthroscopy, where they're actually going in and visualizing the joint, doing small repairs. to an arthrotomy where they're making an incision and they're actually doing some type of repair, whether it be just a plication of the disc or putting the disc back into position or suturing back into position, and or partial or total joint replacement. Those are much more rare. I would say that of 1,000 surgical cases that I've seen over 35 years of working in this area, that I would say I've probably seen less than 50 total joint replacements. Mm-hmm. So the majority of cases are just arthroscopies that, and they're about 82% successful across the board, statistically.
That's awesome. Well, we're so thankful for prevention and doctors like you that, you are dealing at the root cause of the problem and can help the patient before it becomes irreversible. So we like to hit it, kick it in the butt, find out the root cause, deal with anxiety, get the mouth guards, get physical therapy. So you're so wonderful. I love you. How can the patients find you?
Oh, thank you. It's a pleasure working with your cases. I was thinking about it earlier. Your patients love you. They come to me from your office, and they're just, it's very unusual. Let's put it that way. To have patients coming in and think so highly of their physician. So it's a great testament to what you're doing over there and your staff.
We're trying to be more than a tooth doctor. I'm trying to be knowing what we know after 35 years of experience. We have a lifetime experience in medical stuff, nutrition, fitness. So we're very comprehensive. And I like to counsel my patients from A to Z because they don't know any better. They're doing something wrong and you know it. Well, that's my responsibility. So they know I take it very seriously. And I want them to go and see you more because there are things that you can do for them in a few visits that will change their world.
Appreciate that.
So where are you located and how can they find you?
Well, I'm located in Fort Lauderdale. I'm on Oakland Park Boulevard, just east of US 1, not too far from your office.
Yes.
We have a website, which is accucare.net, ACCUCARE.net. And my email, if you want to reach me directly, is Kurt, K-U-R-T, Klein, K-L-E-I-N, P as in physical and T as in therapist at yahoo.com. Kurt Klein, PT at yahoo.com or accucare.net. Or I'm at 2655 East Oakland Park Boulevard in Fort Lauderdale.
That's awesome. Or they can call us and we'll give you the information.
Yes, I appreciate that.
Yes, I love you. Thank you so much for your time, Dr. Klein. That was wonderful. And I cannot wait to hear more people getting the care that they need. It's so simple and it'll change their world. I have patients that have gone to you with 30 years of headaches. And then they cannot believe it. Oh, he cannot help me. What can he do for me? Trust me. Go and they're like, they fall in love with you. They're like, I cannot believe that this took care of this pain that I suffered for 30 years. So I just pray that people will be open-minded about doing the simple things before they need surgery.
Right.
Thank you so much. Have a blessed day. If you have any questions or suggestions for further future topics, please leave a comment below. Thank you.